So the next topic is removable appliances. In this we'll be talking about the various removable appliances, the most important ones mainly, the components of a removable appliance, the parts and the other features. First question is, anchorage in a removable appliance is provided by the acrylic plate because this is the passive part and the rest all are active. So the removable orthodontic appliances are mainly classified or rather made of three components: the retentive components, that is the clasps, the active components, which are the springs, screws or elastics, and the anchorage unit or the base plate or the framework, which is made up of acrylic, either cold cure or heat cure. Removable appliances bring about mainly tipping because it is the simplest form of tooth movement, where the rest of the bodily movements are achieved by the fixed appliances. Now we come to Adams clasp. Over here, the angulation of the retentive portion at the bridge is angulated at an angle of 45 degrees. The length of the bridge is usually 2/3 the width of the mesodistal width of the tooth or the distance between the two buccal cusps. When you view it from the side, the bridge should be at an angle of 45 degrees to the tooth and 2 millimeters away from the surface of the tooth on the buccal side. Which of the following statements regarding the adjustment of the Adams clasp for a proper fit is true? It is number 1 and number 2. That means bending the arrowhead slightly towards the tooth and bending at a point buccally to where the tag makes contact with the teeth at the contact point. Now, when we talk about adjustment of the Adams clasp for a proper fit, it is these two. The third one is for a different purpose, which is when you want to tighten the appliance, what you do is you hold the arrowhead with the clasp and you bend it towards the undercut of the tooth. Okay. Whereas if you want to adjust the height, here you hold the wire where it exists from the acrylic and then you bend it up and down. Because sometimes when the clasp is not made very well, it goes very high up on the teeth. So it interferes with occlusion. So when it interferes with occlusion, you bend it at the point where the wire emerges from the acrylic. But when you want to tighten it or make it fit better, you adjust from the arrowhead area. You got it? Which of the following clasp is indicated when retention in mixed dentition stage is required for an erupting premolar region? In this case, it is a triangular clasp, but if an Adams clasp is given, if that is the choice, then it is always Adams clasp because that is a universal clasp which is given for almost any kind of situation. So this is the diagram of a triangular clasp. As the name suggests, it is triangular in shape, and triangular clasps are small triangular shaped clasps that are used between adjacent posterior teeth, and they engage basically in the undercut between those teeth. They are mainly used for additional retention, and many a times it is used in case of a mixed dentition period. There are two more other clasps. One is the south end clasp, which is the one in black and white, and there's a ball end clasp, which is basically a little ball at the end of the clasp. The south end clasp is usually like a double U shaped, and this is specifically used in the anterior region for retention, whereas the ball end clasp is used for additional retention when removable appliances are used with a fixed appliance as such. Next is the Schwartz clasp. It is also called the multiple arrowhead clasp, and it was a predecessor of Adams clasp. That means it was developed before the Adams clasp and it was designed by Schwartz. It consists of multiple arrowheads which are engaged in the interproximal undercuts between the posterior teeth. Which of the following cannot be used for incisor retraction? It is the high labial bow. Now this is a diagram of a high labial bow with apron springs. Now the reason why this cannot be used for retraction is the appliance, or rather the labial bow, for example split labial bow, which is given on the right side rather, is used for flattening of the arch, diastema closure and also retraction, and it's made by a 0.6 millimeter wire. Whereas the other type, the diagram of which is shown on the other side, it is a Roberts retractor. It is used to retract procline anteriors. It's made of 0.5 mm wire. So these two can be used for retraction, and split labial bow can also be used for diastema closure, but high labial bow as such cannot be used for retraction of anteriors because firstly because of the position of the labial bow, it is high into the vestibule, and also although there are apron springs attached to it which touch the anteriors, those apron springs do not exert that much of a force to recline the anteriors. Which of the following is a labial bow? Now all these are examples, or rather the different types of a labial bow. High labial bow, Roberts retractor and Mills retractor. So these are the types of labial bows, and this is the description of it. The short, long and split labial bow, all three are made up of a 0.7 millimeter wire. Short labial bow extends from canine to canine, long from premolar to premolar, and split, it is the same as the other labial bow, but it is split in the midline. That is the difference. So the short and the long labial bow, basically they are used for overjet reduction, and the split labial bow is also used for anterior retraction. Here in the short labial bow and the long labial bow and both the split also, the reduction of the lingual palatal acrylic is done for activation and also compression of the U loops, because the basic structure and the shape and design is the same. When we talk about modified split labial bow and reverse labial bow, again both are made up of 0.7 millimeter wires. In the modified split labial bow, the bow is modified to engage the opposite central incisor. For example, the right one will engage the left central and vice versa. The activation is the same as the previous labial bows, and it is mainly used for closure of the diastema. In the reverse labial bow, it extends from permanent canine to permanent canine or premolar to premolar, and here, apart from the reduction in the lingual palatal acrylic, opening the loop results in lowering the bow incisally, and then a compensatory bend is given to maintain the proper level with respect to the anteriors, and it is mainly used for overjet reduction. Then we come to Roberts retractor. It's made of 0.5 millimeter wire, extends from canine to canine, and there is a helix that is incorporated on either side. The diameter of both the helices should be around 3 millimeters. The activation is done again by reduction of the lingual palatal acrylic and also closing the helices. Here it is used for increased overjet, for reducing the increased overjet. Then there is Mills retractor. It is used by it is made by a 0.7 millimeter wire. The bow has an extensive looping, and the activation is done by compressing the loops. In here it is used to reduce a large overjet. Then there is high labial bow with apron springs, which was discussed and shown earlier, and there is a fitted labial bow. The fitted labial bow can be either made with a 0.7 millimeter or a 0.9 millimeter wire. It is mainly called fitted because it fits exactly according to the contours of the buccal or the labial surface of the anteriors. It is mainly used as a retention appliance after the completion of orthodontic treatment. So high labial bow is used mainly to carry the auxiliary apron springs and indicated for retraction of anteriors with large overjet, and Roberts retractors again for proclination. But between these two, a Roberts retractor is much better compared to a high labial bow with apron springs. So this is the fitted labial bow that can be seen. So it doesn't allow any kind of tooth movement. Okay. So again, the high labial bow is mainly used to carry auxiliary springs, because as such, without the auxiliary springs, there is not much of force that is generated by the high labial bow. A helix is placed for increasing the flexibility and range of the wire. So a helix spring, or rather spring with a helix, it contains an active arm which is around 12 to 15 millimeters, a helix which has a 3 millimeter internal diameter, and a retentive arm. When you place a helix, it increases the length of the wire as compared to when you don't place a helix, and therefore it increases the flexibility and the range of action. So the main effect is by increasing the range of action, and therefore the force can also be decreased by increasing the length of the wire. Now this is discussed in a formula that is given. It will come in the next couple of slides. So thus springs that are longer are more flexible and they remain active for a longer duration of time. Helices can be incorporated into the springs to make them more active. When you increase the length by doubling it, the force can be reduced by 8 times. If you use thicker wires, you decrease the flexibility of the spring and therefore a greater force is applied. So when we talk about the flexibility of a wire, it is directly proportional to the cube of its length. So this is the it is not exactly the formula, but this is the relation of the flexibility to the length and the diameter. So when we talk about flexibility or rather deflection, it is directly proportional to the cube of the length. So the larger the length of the wire, it is more flexible, and it is indirectly proportional to the fourth power of the diameter. K is just a constant over here. So as the diameter increases, the flexibility decreases. And flexibility is also directly proportional to the number of coils. As you increase the helices, again because of length is also increasing, so flexibility is increasing, and it is also directly proportional to the square of the diameter of the coil. So this is another way in which the same formula has been described. Here we talk about orthodontic springs that are made by 18/8 stainless steel wire. It is very ideal. Why? Because it combines elasticity and malleability, and it is also immune to corrosion by oral secretions. So there is a relationship between the amount of deflection, which can be measured in terms of flexibility, and amount of pressure, length of the spring, and thickness or diameter of the spring. So the amount of deflection is directly proportional to the amount of pressure. The more deflection, the more pressure. And also the length of the spring. The more you increase the length of the spring, the more is the deflection or the flexibility, and also it is inversely proportional to the fourth power of the thickness or diameter of the spring. Helix in a finger spring for mesial movement lies in line with the long axis of the tooth. Now whether it is for mesial movement or distal movement, it is irrespective. What is to be remembered is that the helix lies in line with the long axis of the tooth as is given in the picture. The finger spring is also called a single cantilever spring since it is supported only at one end. There are other examples of cantilever spring which are Z spring. It's also called the double cantilever spring, and there's a T spring. Now a description of the Z spring and T spring etc. will be coming in the next couple of slides. So a finger spring is nothing but a helical spring which has an active arm, a helix and a retentive arm, as is typical of usually other springs. And it is mainly used for mesiodistal movement of teeth, for example closure of midline diastema. The spring is constructed such that the helix is positioned opposite to the direction of the intended tooth movement. So if the tooth is to be moved mesially, the helix should be distal, and the helix should also be placed along the long axis to be moved and perpendicular to the direction of the tooth movement. The spring is activated by opening the helix. Either we can do that, or the second method is by moving the active arm in the direction of the tooth movement. The activation is done as close to the coil as possible. That means when you are activating by moving the active arm, then you do it as close to the coil as possible, and activation of up to 3 mm is considered ideal when you use a 0.5 millimeter wire. When you use a larger millimeter wire, that means the thickness is increased, therefore the force is also increased, therefore the activation should be reduced to half. Now the Z spring is called a double cantilever spring, and it is mainly used for labial movement of incisors. It can bring about minor rotation of incisors, but that is not primarily the use of a Z spring. It is mainly used in case of cross bites. It's made of 0.5 millimeter wire, and it contains, it's made of 2 little coils of very small internal diameter, either the smaller the better, and the spring should be perpendicular to the palatal surface of the tooth, and the activation is done by opening the helix or moving the active arm in the labial direction, the same as the finger spring also. Finger spring adjustment in a month should be around 3 to 4 millimeters. So again, this is the diagram. Activation, same schedule. When the wire is thinner, the activation is this much, and when the wire is thicker, it should be a little less. Opening the helix. I'll come to the different types of activations for different types of springs in a couple of slides. So it will be a little more clear as to for what you need to close and for what you need to open the helix. Pratima's question was that. So just give me 2 minutes, I'll come to that slide. The expected rate of tooth movement is between 1 to 2 millimeters a month. So therefore, when you activate it to about 3 millimeters, that should be sufficient till the next appointment. The force delivered by palatal springs increases about 15 grams for each millimeter of deflection, so that an activation about 1/3 of a tooth width, that is 3 millimeters, will deliver force of about 45 grams. Which of the following is used for correction of anterior crossbite? As discussed previously, it was Z spring. Now, Z spring is used for correction of anterior crossbites. T spring is used for buccal movement of premolars and canines. We'll come to a little more description of T spring, coffin spring and canine retractors in the next couple of slides. Now, there is something called a whip spring. It is used for correction of rotation of teeth. So, as you can see, it's not very clear exactly as to how the action is, but basically one end is into the molar area, that is the molar band or the molar tooth, and the other area is fixed on a bracket on the tooth that is to be derotated. So it is used when basically for a single tooth derotation. It's made up of a rectangular wire and a bracket is placed on the tooth that is to be derotated, and the other end is hooked onto a suitable site on the removable appliance, or sometimes even into the molar tube of a fixed appliance. Now, when we talk about a canine retractor, see, although the questions are a little mixed up, we will the basics will be discussed in terms of formulae for deflection, pressure, thickness, etc., the types of activation, and generally the description of the springs or helices or the bows. If a coil and a tag of a palatal canine retractor are placed too far distally, the tooth will tend to be moved buccally. This is because because of the direction of pressure which is at right angles to the active arm. So whenever it is too distal, it usually tends to push the tooth buccally. Buccal canine retractors are used, forget about instead, whether they are used instead of palatal canine retractors or anything else. The main use of a buccal canine retractor is to retract a canine that is placed buccally. So sometimes they might put the question or frame the question in such a way that you might get confused between buccal and palatal. But buccal canine retractor used for retracting buccally placed canines, palatal for palatal. It is as simple as that. So buccal canine retractor or self-supporting canine retractor is a closed coil spring. The main disadvantage is that it displaces the canine buccally and sometimes it intrudes it while affecting the distal movements. Now, again, it consists of a coil of 3 mm diameter, active and a retentive arm. The coil is placed distal to the long axis, and the buccal canine retractor can be divided into two types. There is supported and there is a self-supported. The supported means that it needs some form of support. So it can be used with auxiliary springs when it is supported. Therefore, you will see that a supported canine retractor is of a lesser diameter, that is 0.5 millimeters. So since it is thinner, it requires support. Whereas the self-supported ones already have support because they are around 0.7 millimeters and they are thicker. So the self-supported canine retractors are activated by closing the helix 1 millimeter at a time, while the supported canine retractors can be activated for up to 2 millimeters. Again, because of the difference of the thickness of the wire that is used. Which of the following canine retractors is least effective? It is usually the U-loop canine retractor. And a helical or a reverse loop canine retractor, this one is a reverse loop. It's indicated in patients with a shallow sulcus and mainly in the mandibular arch. Spacing occurs between anteriors when canines are moved into premolar extraction space by a removable appliance, and this is done if the interdental spaces of the acrylic are trimmed away. Now what they try to say is that when you make a removable appliance, the lingually the interdental areas of the acrylic should be absolutely touching the teeth, or they should be in very close quarters or closely related to the teeth. They should not be away from the teeth, because if they are close to the teeth, they avoid movement of the anterior teeth. So the closer they are to the teeth, the better the fitting they are in respect to the teeth, the lesser amount of movement will be of the anteriors. An anterior bite plane should be trimmed to keep the posterior teeth 2 millimeters apart. Usually this is the ideal amount of distance that is the posterior teeth should be when you keep an anterior bite plane. So it is mainly given for the correction of deep bite, and there is a clearance of around 2 to 3 millimeters between the upper and the lower posterior teeth. And when you use an inclined bite plane, the angle becomes around 60 degrees to the occlusal plane. So when you use an anterior bite plane, or this kind of whether it is inclined or whatever it is, with a 2 millimeter opening in the anterior region, it causes a 4 to 5 millimeter opening in the premolar region and a 2 millimeter opening in the molar region. Again, this is because of the presence of the which curve in the mandibles? Yeah, curve of Spee. So what are the things that are true about the anterior bite plane? It helps in the correction of deep bite, eruption of molars, and it also depresses the lower incisors. Inclined bite plane is constructed at 45 degrees to the occlusal plane. The upper inclined plane is constructed at 60 degrees to the occlusal plane, while the lower one is at 45 degrees. Cateline's appliance is used for the correction of an anterior crossbite. Cateline's appliance, as seen in the diagram, is basically just a inclined plane on top of the lower incisors. It is also used for the single tooth crossbite. Now posterior bite planes are given in all conditions except for correction of anterior deep bite. Usually the opposite happens. So it is never ever used for correction of deep bite. It is indicated for correction of anterior crossbite because it relieves the bite in the anterior region. It can be given unilaterally also to correct a unilateral crossbite, but in this case anterior bite plane is used to correct the anterior deep bites. Now example of a semi-fixed orthodontic appliance is a lip bumper. Now lip bumper, why? Because here there are fixed parts and there are detachable parts. Okay, the fixed parts is the one that is attached to the molar tubes, and the anterior part is the detachable parts. Now there are other types of lip bumpers also. The lip bumper of the anteriors, or rather the upper arch, is called the Denholtz appliance, and there is also something called a Bass appliance, which is the diagram is given over here. As long as you just know the names, that this appliance is used in this arch and for this purpose, that should be enough. Pratima has asked me, does anterior bite plane have a posterior occlusion as an appliance? When you use an anterior bite plane, there is disocclusion of all the teeth, including the posterior teeth. So therefore there can be no posterior occlusion when there is anterior disclusion anyways, or even the other way around. So when you are asking specifically about anterior bite plane, obviously there will be a posterior disclusion, and we, as discussed earlier, 2 millimeters, 4 to 5 millimeters, and again 2 millimeters in the posterior region. So this diagram shows the basic the action of the lip bumper and the position and the form. So the first part, the number A, this shows the mode of action of the lip bumper. So basically when it shields the muscular activity of the lower lip, it also helps in relieving the crowding of the lower incisors. Now the second picture adjacent to that shows a prefabricated lip bumper without the molar tubes. It has a lip pads in the front, and the second one shows the one with the molar loops. That means now these loops come mesial to the molar tubes so that it doesn't get pushed backwards. Also, conversely, when the muscular action or the muscular force is transferred to the lip bumper, this kind of molar loops or molar stops helps in distalizing the molars. The B shows the upper lip bumper, that is the Denholz appliance, and C shows a lower removable lip bumper, and the D shows a lower fixed lip bumper, that is fixed to the molar tubes. Now for a removable orthodontic appliance to be effective, it needs to be worn for at least 4 to 6 hours in a day. Which of the following is not an active component? It is an Adams clasp and a base plate because it's used mainly for retention. Adams clasp can fracture in use if the tags are very high on the bite. Sometimes we don't make it very well fitted. So like was discussed previously, one of the methods to alter the fitting in the vertical dimension is by adjusting the wire when it comes out from the acrylic. So in this case, when it is very high on the tooth and it disrupts the occlusion, that kind of adjustment can be done. So the Adams clasp was described by Adams. It is also known as Liverpool clasp or universal clasp or modified arrowhead clasp. It is constructed using a 0.7 millimeter stainless steel wire, and it can be used almost in any kind of a situation. So the retentive part, now these kind of things you are usually well versed with. Now the Adams clasp, sometimes they don't ask directly whether is it 0.5 or 0.6 or 0.7, they'll ask the mil. So here it is 28 mil wire. Okay, so this is the component and the diameter. When you use Adams clasp, it is 22 gauge or 0.7 millimeter or 28 mil. Low labial bow is again 0.7 millimeters, high labial bow is 1 millimeter. Lip bumper is 0.9, Roberts retractor is 5. Most of the springs are around 0.5 to 0.6, and that is the conversion when you convert mil into inch into millimeters. So 1 mil is actually 1,000th of an inch, which is equal to 0.025 millimeters. Now, whereas Adams clasp is concerned, we must remember all the three conversions, that is 22 gauge, 28 mil and 0.7 millimeters. So this is the conversion of the other dimensions, that is 0.5, 0.6. So if you remember 0.5, 0.7 and 1, that should be good enough. 0.7 being the most important. Which of the following clasps is preferable on a partially erupted tooth? Again, it is Adams. Specifically for a partially erupted tooth, you can use an Adams clasp with a single arrowhead because that is easier to engage and it can easily go into the undercut of the tooth. Now there is something called south end clasp, which was described earlier also. It is mainly used in the upper anterior or central incisors. You have to adapt this to the cervical margins of the central incisors, and the distal ends are carried over the contact points and they go as the retentive arms on the palatal side. The diameter of the labial bow used for retention. Normally it is a little less, or maybe it is 0.7, but for retention purposes it would be a little higher. That means 0.7 to 0.8. Short labial bows 0.6. Normally for retraction, 0.7 for retention, and sometimes 0.9 to 1 for reinforcement. Roberts retractor is, out of all of them, it's a mechanical appliance. Now I'll get to that part where it shows, okay, I'll come to that. Which of the following is a guided spring? A guided spring is nothing but a cantilever spring. A cantilever spring has helices and basically it guides the spring for the direction of movement. Now, based on the presence or absence of helices, springs are classified as simple, that means without helix, compound with helix. Based on the presence of loops or helixes, helical springs obviously have a helix and the looped ones have a loop. And based on the nature, self-supported ones, they are made of a thicker gauge and they can support themselves, like the self-supported buccal canine retractor. And the supported ones, they are made of a thinner gauge. So they lack adequate stability. Now this diagram over here, it shows a spring that is encased in a metal tubing. If you see the distal part, it's thicker than all other parts. So you have put a metal tubing to protect it, or it is encased in a hollow acrylic which acts as a anterior biplane and prevents its distortion during function. Now this again was described previously. When the diameter of the wire is doubled, the flexibility or deflection of the spring decreases by 16 times. Because you have to, when you talk about the deflection, the thickness of the diameter, it is t to the power 4. It is not 4 into 2, 8. It is the square of 4. So 4 into 4, 16 times. So you have to carefully read the question. Are they talking about force exerted? Are they talking about pressure? Or are they talking about flexibility? Depending upon that, you have to figure out what part of the equation are they asking for. This is also another equation which is almost the same. Again, force or pressure exerted is directly proportional to the fourth power of the diameter, and the cube inversely proportional to the cube of the length. What is the effect of doubling the diameter of a cantilever spring? Again, strength increases by 8 times, but springiness decreases by 16 times. If the diameter is doubled, the strength is increased by its cube root, and the strength is directly proportional again to the power of the diameter. So these ones are, again, if I describe this, it will be very confusing. So if you just put the values according to the formula, it will be easier. So again, there is stiffness, there is strength, and there is range. Now stiffness depends on modulus of velocity. It is inversely proportional to the cube of length, directly proportional to the fourth power diameter, inversely proportional to the number of coils, and inversely proportional to the cube of the coil diameter. Whereas strength is directly proportional to resiliency, inversely proportional to length, directly proportional to cube of the diameter, and inversely proportional to the coil of the diameter. The range is directly proportional to the elastic limit and to the cube of the length, inversely proportional to diameter of the coils, directly proportional to the number of coils, and the square of the coil diameter. I think D is a deflection. D is a deflection, and the last one is the coil diameter. D is not the coil diameter, it's a deflection. The angle formed between the tooth movement and the place where the finger spring first touches the tooth is 30 degrees. So the direction again is determined by the point of contact between the spring and the tooth. An undesirable side effect commonly associated with the finger spring is intrusion of the tooth, because again of the position and the placement of the finger spring. Springs used for buccal movement of a premolar is a T-spring as shown in the diagram. Now T-springs and flapper springs. Now the lower one, the flapper spring, is called a mousetrap spring, because usually when you see how a mousetrap is, the shape is very similar to a flapper spring. So this is used for buccal movement of posterior teeth, and finger springs are also used for mesodistal movement, like you know. There is something also called a W spring, which is sometimes used for slight amount of expansion. How or where should the wire be bent to activate a correctly made palatal canine retractor? It is between the coil and the tooth, but close to the tooth. Now here is where This is the question which Pratibha had asked. Now before coming here, I'll just go back to this question. Following spring is activated by closing the coil, that is buckle canine retractor. Now this is something which you will have to remember by heart. Buckle canine retractor, again because of the shape, it is closing the coil. When you talk about a labial bow, you close the loop, and when you talk about T-spring, you elongate the spring. All the other retractors or other springs, that is palatal canine retractor, finger spring and Z spring, are activated by opening the coil. So basically buckle canine retractor is the only one in which the activation is done by closing the coil. So I hope Pratibha's question is answered. So keep this in mind and always remember this part. Buckle canine retractor closing, rest are opening, labial bow again closing the loop, and T-spring is elongating the spring. Springs used for maxillary arch expansion are quad helix and coffin spring. Both of them can be seen on diagram. The quad helix was described just a minute. Yeah, Monica also described a good way in which you can remember. Buckle is mouth and we close it. So therefore buckle canine retractor can be activated by closing the loop, and since fingers are opened, according to me fingers can be closed also, but anyways, finger spring, Z spring, opening the loop. Now springs, so when we talk about a quad helix, the easiest way to remember is quad means 4, so you have 4 helices, and coffin spring, again we know the diagram and the shape of a coffin spring. So we know what is the use of the retractors. Now there is something called a Dontrix gauge. It is used to measure the amount of force that is applied by any kind of appliance. So this is the diagram of a Dontrix gauge. Now usually it measures the pressure and the force, and there are two types of gauges that can be used to measure the force. One is a spring type gauge, which is the Dontrix gauge, and one is a dial type gauge, which is called the Corex gauge. Now the Dontrix gauge has a spring inside, so therefore, and it has graduated readings on it, which you can read off directly. So the measuring range is between 28 to 450 grams. Now this is calibrated in ounces. So as you can see in the picture here, you can see that both ends are somewhat hooked. So one end is hooked to one part and the other part you catch. So when you pull it, when you have the other end also engaged to another part of the appliance, and when you pull it, you can see the where the mark is coming on the graduated part on the gauge itself, and you can read the measurement directly from the gauge. There is something called a Corex gauge, which is a dial type gauge. The calibration is in grams, and there are about 4 different gauges available in that according to the amount of force that can be measured by each gauge. There is a number 1, 2, 3, 4, that means 10 to 100, 25 to 250. Third one is actually 250 to 500 and 500 to 1000, depending upon the type of force or rather the range of force that we are going to measure. Anterior bite plane, again it is used to correct deep bite. This is being repeated over and over again. So this is a little recap of bite planes. There is an anterior bite plane. It is used for correction of deep bite. There should be a clearance of 2 to 3 mm between the upper and the lower posterior teeth. That means that would give space for supra-eruption of the molars, and therefore the deep bite would get resolved. When we talk about a posterior bite plane or a upper inclined bite plane, it can be used along with a Z spring. It is used in treatment of a anterior cross bite, and this is an example of reinforced or multiple anchorage. And here the inclined bite plane is at an angle of 60 degrees to the occlusal plane, and the mandible is used to reinforce the anchorage by the engagement of lower incisors onto the upper inclined bite plane. So therefore there is a distal force applied on the maxillary teeth. There's something called a Swed biplane. It is a modification of the upper inclined biplane with additional incisor capping. It has an advantage of splinting the incisors to prevent them from being forced labially. So it is also an example of a reinforced anchorage, and that was one of the questions asked, I think, in 2006. The Catalan's appliance, or the lower anterior inclined plane, it is inclined at an angle of 45 degrees to the occlusal plane, and it is used to treat maxillary anterior single tooth developing crossbite. It can be either made in acrylic or in metal, and it should not be worn for more than 6 weeks, otherwise it can lead to the complete opposite, that is open bite. Again the same question is repeated, so you more or less remember this. Now what is a wrong statement about anterior bite plane? That means it is indicated in high FMA cases. Now when you put an anterior bite plane, there is supraeruption of posteriors, therefore anyways the FMA will increase. So you don't want to give it in a patient who already has a high FMA. So that is a contraindication. Which of the following is true about a Catalan's appliance? It is constructed on lower anterior teeth with an inclined plane, as discussed previously. So this is a Catalan's appliance. It's the diagram. The prerequisites for the Catalan's appliance is that there should be enough space in the maxillary arch to align the teeth because of the pressure that is applied. The maxillary teeth should be corrected. The maxillary teeth to be corrected should be retroclined or erupting posterior to the actual tooth position, because when it occludes, it gives a kind of a buccally erupting force. And the mandibular teeth should also be strong enough so that they can absorb or be able to tolerate such forces. The disadvantage is that the patient cannot really speak or chew properly, and because it has an anterior bite plane effect, it can lead to an anterior open bite. That is one of the side effects if it is used for more than 6 weeks. Again, posterior bite plate is used in correcting the anterior crossbite. Speech problems associated with the removable orthodontic appliances are difficulty of lingual vowels for a few weeks. So when you give a removable appliance, suppose you give a retainer to a patient after orthodontic treatment, you will find that the patient is not able to pronounce certain letters like L, N, T also. So these kind of lingual alveolar consonants will be difficult for a few days. As time passes by and the patient gets more and more comfortable with it, these words become a little more clearer. But initially, linguoalveolar consonants are almost they're just not very clear. How long should a palatal crib be worn by a patient being treated for a thumb sucking habit? It is usually 6 months or longer. Now, thumb sucking, tongue thrusting, these kind of habits, they're anyways developed over a very long period of time. So ideally, the longer you keep a tongue crib or any kind of this appliance, habit breaking appliance, the better it is, because 6 months usually is also not a very great amount of time to undo the effects of that. But 6 months is a minimum time period for which you need to apply a habit breaking appliance. The loops of the tongue crib are removed one by one as the patient is weaned from the habit appliance over a period of 6 months. Now usually when you call the patient for a checkup every month or so, you need to determine how well the progress is being. So if you still feel that the tongue thrust is happening and the patient is not showing any kind of positive improvement or something like that, then the cribs need not be removed. Then they have to be probably continued for a larger period of time until you see some amount of improvement. So this was about removable appliances.